Hi, everyone. Thank you for joining me today. My name is Maly Tiev. I'm currently working as a nurse practitioner at NYU Langone Health in New York. For today's program, I'm going to discuss two cases to illustrate the difference between F3 and F4 fibrosis and how this influence treatment, prognosis, and surveillance strategies. Please use this QR code to register for this meeting. So our first case is case 6A. Sam is a 55-year-old Caucasian male, and he was referred for mildly elevated transaminase level, and his abdominal sonogram shows increased liver echogenicity. He complains of fatigue. His medical history includes type 2 diabetes, hypertension, hyperlipidemia, and sleep apnea. He does not drink alcohol. On physical exam, he has obese abdomen, no stigmata of advanced liver disease, and no hepatosplenomegaly. His medication includes lisinopril, rosuvastatin, ezetimibe, and dapagliflozin. His vital shows that his blood pressure is 140/78 and his BMI is 33. His lab shows elevated ALT of 85, AST 72, with normal alkaline phosphatase, total bilirubin, and platelet counts. His A1C is 7.1. His creatinine and INR are normal. His ferritin is elevated at 780 with an iron saturation of 30%, not consistent with hemochromatosis. And his autoimmune and viral hepatitis panel were negative. So based on these findings and on physical exam, Sam have been diagnosed with metabolic dysfunction associated steatohepatitis or MASH. So the next step is to assess for fibrosis so that it will guide us on how to manage him. So using NITs, these are his fibrosis assessment. FIB-4, this is a simple online calculation that you can do using age, ALT, AST, and platelet counts. If you are using EMR like Allscripts or Epic, this will automatically be calculated for you. So his FIB-4 is 2.74. So we look here on the right-hand side, that put him in that intermediate risk category. His FibroScan test shows 11 kilopascal. So if you look on the right, that's F3 fibrosis. His GAP score is 262, showing moderate steatosis. And his ELF blood test, this is a send-out blood test that you can do with Quest or LabCorp, and it came back 9.9, putting him in that severe category, F3. So all three of his NITs taken together is pointing to MASH with advanced fibrosis F3. So is there any further testing you'd like to perform on this patient? And how would you stage this patient? So at this point, some clinician will wonder, is it necessary to do another test like an ultrasound elastography or MRI elastography? I think that in this patient, since all three of his NITs are pointing to the same thing, showing F3, that maybe a fourth NITs may not be necessary unless you feel that his FibroScan test is not so accurate, because FibroScan test does have certain influence that can affect the results of the test. So you feel that the FibroScan test may not be too accurate, then ultrasound elastography or MRI elastography would be an option. As far as liver biopsy goes, some people would wonder if a liver biopsy is necessary for this patient. So in my experience, if you have multiple NITs that align, that you can avoid an invasive procedure like a liver biopsy. So based on all his NITs, I would stage this patient with MASH, advanced fibrosis, F3. So let's discuss how we would treat and monitor this patient. So this patient have F3 fibrosis. So this is the window of opportunity where if you intervene and start treatments, you can potentially either halt or reverse his fibrosis. So I would start this patient on resmetirom or Rezdiffra. Resmetirom was FDA approved a year ago for adult MASH patient with F2 or F3 fibrosis. You also want to counsel this patient on lifestyle modification, focusing on weight loss of 7 to 10% and healthy eating, as well as incorporating exercise. For this patient, I would consider GLP-1 for his type 2 diabetes. This will offer dual benefits, weight loss and improvement in hepatic steatosis. Recent studies have demonstrated that GLP-1 can improve fibrosis, but currently not FDA approved for MASH. Current guidelines do not recommend routine hepatocellular carcinoma screening in non-cirrhotic MASH. However, we know that patients with MASH can develop liver cancer in the absence of cirrhosis, and the risk is 0.2% per year. But this risk increases if the patient has type 2 diabetes with obesity and advanced fibrosis. So in my practice, I do screen these high-risk patients for liver cancer using AFP and abdominal ultrasound every 6 months. And finally, you want to repeat his NITs in 1 year. Now, imagine that you have the same patient profile. So this is our second case, 6B. So this patient have the same medical history, the same physical exam, the same medication, the same vitals, but when it comes to lab, this patient total bilirubin is a little elevated at 1.4, and the platelet counts is now 128,000. So if you have any patients with a platelet count less than 150,000, you want to really start thinking about cirrhosis unless proven otherwise. His creatinine is a little elevated at 1.3, and the rest of his labs are the same. So you have the same patient's profile, but now different NIT scores. So on FIB-4, this patient has 3.36. So you look on the right, this shows that the patient has high risk for significant fibrosis. On FibroScan test, it shows 21 kilopascal. So if you look on the right, that's F4 cirrhosis. The CAP score is 246, showing mild steatosis. And the ELF score is 11.4, showing F4 cirrhosis. So taken all together, his NITs are showing MASH with cirrhosis, F4. Now, is there any further testing you'd like to perform on this patient, and how would you stage this patient? So at this point, similar to the last patient, you have all three NITs that's pointing to F4 cirrhosis. So perhaps a fourth test may not be necessary unless you feel that the FibroScan test is not so accurate. For this particular patient, sometimes providers may want to think about doing a liver biopsy. So if you have a patient with non-invasive testing that's pointing to cirrhosis, but you don't really think that this patient has cirrhosis of the liver based on imaging and other assessment, then you can potentially consider a liver biopsy and see if this patient actually have F3 and not F4. However, if your NITs are showing cirrhosis and you have imaging that shows evidence of portal hypertension, or you have upper endoscopy that shows the patient have portal hypertension, I would not do a biopsy in this patient because clearly this patient has cirrhosis of the liver, and doing a biopsy would not change your management. And so for this patient, if you're not doing a liver biopsy and you're assessing this patient on his non-invasive testing, I would stage this patient with MASH with compensated cirrhosis F4. So let's discuss how you would treat this patient and monitor this patient. So for this patient, because he has cirrhosis of the liver, he does not qualify for treatment with resmetirom. Resmetirom is only FDA approved for patients with F2 or F3 MASH, not yet for cirrhotic patients because there's no safety data in this population yet. So you want to counsel this patient aggressively on diet and lifestyle modification, focusing on weight loss of 7 to 10%, really discussing with patient healthy diet and incorporating exercise. For this particular patient, you will need to screen this patient every 6 months with AFP and ultrasound for liver cancer. Now, according to Bavino's 6 criteria for compensated cirrhosis with a FibroScan test of less than 20 kilopascal and liver and platelet counts above 150,000, you would not need upper endoscopy to screen for esophageal varices. But for our patient here, his FibroScan test is showing 21 kilopascal and his platelet count is 128,000. So therefore, this patient would need an upper endoscopy to screen for esophageal varices. And if his EGD shows that he has medium or large varices or even small varices with high risk features for bleeding, you would want to start this patient on primary prophylaxis with non-selective beta blocker to prevent bleeding. So let's take a step back and recap. So we have 2 patients with the same history profile. So for patients 6A, his FIB-4 is 2.74, his ELF score is 9.9, and his transient elastography is 11 kilopascal, all pointing to F3 fibrosis. So for this particular patient, he's at that window where if you intervene, you can potentially halt his fibrosis or even reverse it. While patient 6B, the FIB-4 is 3.36, ELF score is 11.4, and his transient elastography is showing 21 kilopascal, all pointing to cirrhosis of the liver. So therefore, your management for this patient shift to cirrhosis management and lifelong HCC surveillance. So these are a couple of our discussion points. So how do these 2 patients compare in management? Really, the big difference between these 2 patients is that the patients with F3 qualify for treatment with resmetirom, while the patients with F4 currently do not qualify for that treatment. And as far as staging between F3 and F4, which NITs do you most typically used to differentiate between the 2? So the idea here is that you should use multiple NITs to adequately assess your patient fibrotic stage. And similar to what we did with our 2 cases, you want to use different combinations. So I think that in clinical practice, the most common would be the FIB-4 test, the ELF score, the FibroScan test, ultrasound elastography, or MRI elastography, but you don't have to stick to these. There's other non-invasive testing as well that you can use. Now, what about indeterminate NITs? So for those patients with inconclusive NITs, you still have liver biopsy available to you to differentiate which stages they have. And liver biopsy is also an option, especially when treatment decision depends on precise staging, like we discussed earlier. If the patient, NITs are showing cirrhosis, but the patient doesn't really have cirrhosis, and your liver biopsy shows F3, now you can potentially treat the patients with liver-directed therapy like resmetirom. And then finally, HCC surveillance, when should you do it? So for patients with cirrhosis, you definitely need to screen these patients every 6 months with AFP and imaging. For those patients, like I mentioned earlier, with F3, currently the guideline does not recommend routine screening. However, we know that these patients with advanced fibrosis, in particular with type 2 diabetes and obesity, they have increased risk of developing liver cancer, so you can consider surveillance in those patients as well. This program is part of the GAP MASLD MASH community network. So please scan this QR code on the right to access additional educational content, including disease state education and risk differ Webcast. And with that, I'd like to thank you for your attention. We have time for Q&A. Are there any questions for me?